Schecter. I'm a general dentist and I practice in Toronto, Ontario, Canada. I've been in practice for almost 30 years and have had the good fortune of being involved with dental implants since its first introduction to the North American marketplace back in 1982 here in Toronto at the Toronto Implant Conference. I utilize dental implants as a integrated part of my treatment planning and will not rely on implants as a last resort, but will look at it as a primary treatment option where needed when teeth are deemed to be hopeless. And today we're going to be doing a live surgical procedure on a recently extracted upper right first premolar tooth, and this will show the dental profession that it is feasible to take out a tooth, even a multi-rooted tooth, and place a dental implant into the available bone and do whatever is needed to augment the defects in the bone, to provide stability, and then to as well give the patient a immediate tooth replacement. The implant is really has to be considered only as a root replacement, but really what patients are concerned about is their aesthetics, their function, their esteem, their smile, and it's no longer acceptable to just go back to the original Brandemark protocol of early implant dentistry, where we would place the implants, cover them up, and then just leave them alone for 4 to 6 months or 3 to 6 months, and then subject the patient to a second surgery. But in that interim healing phase, the patients would be grossly inconvenienced and would have to usually wear some type of a temporary restoration that they really couldn't function with adequately. So the purpose of what we're going to do today is to show you how, even in a difficult situation, slightly compromised, we can place an implant, we can restore the missing tooth space and give the patient what they want, and that's a visible tooth. And we're going to show you how to do that. The patient that is in the chair to have this procedure done on is a relatively young male in good health who had a severely deteriorated upper right first premolar tooth where the roots were decayed and the tooth was non-salvageable. We extracted the tooth, and for this surgical site we're going to be using the new Nobel Active implant as developed by Nobel Biocare. We've chosen this implant because it will allow us to place the implant into this site, which otherwise would normally have to be left unattended for 4 months to allow healing for the bone to fill in. This implant has very specific properties which we will explain as we're going along in the procedure, but the most important thing is that this implant is self-cutting, it is very sharp, and its apical grooves allow us to have a minimal osteotomy preparation site, and we can engage the bone and actually reorient the implant in the available bone into the exact perfect position to receive hopefully an immediate temporary. We will also go through this morning the protocol for deciding and electing whether we can do an immediate temporization, and hopefully the bone will prove to be sufficiently sound to allow us to do so, and then we will show you how we can fabricate an immediate temporary. So this x-ray here that you see on the screen is the post-operative radiograph of the extraction site. As you can see, there are 2 root sockets left, and we're going to be penetrating through from the buccal through to the palatal socket and up into the host bone up here, and then I'm going to be manipulating the implant and reorienting it so that the implant will be hopefully, as we call, dead center in the middle of the socket site. And as one could imagine, this will leave a void on either side, which we are going to be filling with some bone grafting material, which again we'll talk about later. And we will then close up the site and be, as I said, hopefully able to make an immediate temporary. So I'm going to just now pull up the Panorex, and this is the panoramic X-ray of the extraction site. And as you can see here, there is a prescribed calibration pin that we place onto the film before we, or onto the patient before we take the Panorex. And I'm going to use my calibration tool to calibrate so that I can know how much available bone I have. So this pin is actually 20 millimeters in length. It measures 11.6, as you can see. So all I'm going to do is recalibrate to 20. And then I'm going to choose my site where I want to go. And I have 13.5 millimeters. So I'm going to be putting in an implant that will be 13 millimeters in length. So what we're going to do is make a very small sulcular incision around the adjacent teeth. And as you can see, we got really nice healing in 24 hours. And I'm going to reflect the tissue back completely so that I can actually see the site. And when we do this, I want to be able to peel this back so I can actually see the bone completely exposed. So I'm just going to spend a few minutes here just cleaning this, getting rid of all the tissue that I don't want. That's good. You see, I've got a good buccal plate here, which is what I want. Now I'm going to do the same thing on the palatal aspect. But I'm going to just undermine this a little bit. So the key to good tissue management is really in the initial flap design, just to make sure that everything's nice and clean, and then it will suture back really nice and easy. Now we're just going to take a spoon curette. We're going to clean everything out that we don't want. So that's pretty good now. We've got a relatively exposed, clean surgical site. We have a little bit of a defect over here next to this tooth, which when we do our bone grafting, we're going to fill in as well. And we're back down to the original socket. Second here. So just to make life easy, I'm going to just pull the tissue out of the way. So I'm just going to suture the palatal aspect of the flap out of the way, so it'll make life easier for me. And obviously with a patient who has a beard, you want to make sure you just suture the suture, not the beard. I'm going to wrap it around the tooth just so I can keep the this allows me to keep the palatal tissue out of the way. So if you look at this, there's an oblong shape to this socket. Here's the palatal root. Here's the buccal root. So if we could reorient for everybody. This is the buccal root space. This is the palatal root space. And there's a tiny little piece of septum here in the middle. What we're going to be doing is we're going to actually penetrate this septum like this, angled a bit towards the palatal, and I'm then going to be manipulating the implant when I place it and turning it vertical. So the orientation of my drill is going to be towards the palatal where there's more bone. And I want to preserve this buccal plate because the buccal plate is much thinner than the palatal aspect. And I'm going to go apical to where the root is. And then I'm going to, as I said, when I place the implant, because this implant is self-condensing, it's going to allow me to push the bone from the palate towards the buccal and help fill in the empty space on the buccal aspect. This here is our surgical kit for the Noble Active implant system. It has all of the drills in 2 lengths. So these are the exact same drills that are used for putting in any straight-walled Noble BioCare implant, whether it's a replace implant or a Brånemark external Hecht implant. It has each drill in 2 lengths. These drills on this row here are 7 to 15 millimeters in length. These drills down this row are 10 to 18 millimeters in length. And I want to put in a 13 millimeter implant. So if I take my pilot drill, and you can see all the drills have marking lines on them. Every drill has a series of lines on it that correspond to various lengths. So on a 10 to 18 millimeter drill, you're going to have a 10, a 13, a 15, and then an 18 millimeter line. So we're going to be drilling 13 millimeters, so we're going to go to the second line. And in any straight-walled implant system, what you want to do is start with a very small diameter drill, which is our pilot drill, which is 2 millimeters in diameter. And then we're going to slightly enlarge sequentially the hole until we get to a size that's going to be just slightly narrower than the implant. So the implant body itself will cut its way through the bone. And that creates the stability for the implant. So we're going to start with our pilot drill. We're drilling at 2,000 RPMs, again, which is a higher speed than the tapered implant system, because these implants are much more efficient in their own cutting. The tapered implants don't cut, and therefore we have to drill at a slower speed and preserve the bone, and the implants are put in to a different torque setting. So, as I said, I'm actually going to use, just again, this here is a drill extension piece. So I'm going to put this into the handpiece, and it allows me to have a longer working length so that I can seat the drills into the extension piece. So the hardest drill is really your penetration drill. A lot of water. So that's my pilot drill. I'm now going with a 2.4 diameter drill. It's actually 2.4, it's called 2.4, 2.8 because it starts at 2.4 and then it flares a little bit to a 2.8 diameter. And actually I can feel that there's more bone, so I'm actually placing I'm going to place a 15 millimeter implant. I only took out a 13, you're going to have to take out a 15 millimeter. So this here is my 2.8 3.2, and now I'm actually going to go up one more step because I'd really like to put in a 5 millimeter diameter implant. Now it's 5 millimeter diameter on the body, but in the Noble Active system, the top of the implant, the restorative table, is the same. So you can see I'm angled a little bit towards the palate, which is fine, because I'm going to re-angulate it with my implant insertion. So this here is a 3.8 4.2, and I'm not actually going to drill the whole length of it. I'm only going to open up the top part. The implant itself to grab the rest of the bone. And that's it for the drilling. That's how quick it is. We can use the handpiece with a driver. So this is a surgical driver. This driver is inserted into the implant head. And this would go into the handpiece, and then we would pick up the implant and place it under a controlled torque insertion of no more than 45 Newton centimeters on the torque setting. Okay, another way of doing it would be to use the hand wrench, and the hand wrench has a movable attachment that you place the driver into the attachment piece, put it into the wrench, and then we can go ahead and we can insert the implant that way. A more controlled way is to use a hand driver. This is the hand driver. And again, we place the driver into the hand instrument. I'm now going to open up the implant. The implant comes, first of all, labeled in a sterile package. It's got a double seal, so you strip this down. This is a 5 by 15, so it's a 50 millimeter long implant in the Noble Active system. It has a peel-off label on the vial, which verifies that it's Noble Active internal connection, 5 millimeters by 15, and it has a reference number and a lot number. It's very important to keep this information, because we take one of these labels, we put it into the chart, and that way we have a permanent record of what's in the patient's mouth. If there should be a failure of any kind, the implant company will warranty these implants and replace it at no charge. So it comes in a titanium sleeve with a cover. This here is the implant. And as you can see, I'm going to take the hand driver. I'm going to engage it. So that's what the Noble Active implant looks like. It has, I don't want to touch the implant because we never touch these implants with the hand. The implant has the Tyenite surface, which we're going to talk about later, which is a modification of the surface to again promote faster healing. It has a very unique groove system that is designed to promote stability. These implants are very stable in the bone initially through mechanical stabilization, allowing for immobilization so that the bone will heal around the implant and ultimately fuse to the implant. So what I'm going to do is I'm going to place the implant. Hold on. Just with some finger pressure until I can get some stability. So it's now fairly tight. Give me a little bit of water, please. And again, Thierry's not touching the implant with the suction. Now what I'm going to do is go back to the hand wrench. Open the bone. I'm actually going to have to remove this. It's in my way. So you see this, if I pull the bow, I'm already at 70 Newton centimeters. That's stable. That's how stable these implants are. They're unbelievable. But what I want to do, I don't want to exceed more than 70. So I'm going to take this little arrow here, reverse it, make sure this little neural knob is tight, and I'm going to back up the implant a little bit. And now I'm going to turn it back. I'm reorienting the implant to go more vertically in fresh bone. Give me some water, please. And the whole time I'm pulling just the bow so that I'm safeguarding myself not to go past 70. Now I've hit pretty much bottom. So I'm going to again reverse it now. And this allows the implant to cut in the bone. And you can see how much easier it is. So again, I'm hitting bottom. So we're going to back it up again. Now I'm going to go in a forward motion again. Here, can you just hold this? The patient's actually feeling that a bit because he's feeling the pressure. And I'm at 70 Newton centimeters. But I'd like it to, these implants can be placed subosseous because they're all platform shifted, and we'll explain that afterwards so that we can connect our restorative components without worrying about the bone interfering. So these implants can go deeper. And I think we're there. That implant is now rock solid, and we're going to be able to load it up with an immediate temporary. So what I'm going to do is just clean off just a little bit of the bone here that I don't want. There's a defect left in the bone buccal to the implant, where the remnants of the buccal root is. Apically, that area is filled. So if I go down the buccal aspect of the socket here, I'm only going down a few millimeters because I know that the implant has pushed the bone towards the buccal when I reoriented it. So here's our implant. And what we're going to do is we're going to put some bone grafting material into the void space, the empty space buccal to the implant. Then I'm going to connect a temporary component to the implant, and we're going to then make an immediate temporary tooth. We're going to use this material. It's called Connexus from A-Cell Connexus, distributed by Cytogenix. It's demineralized bone in a putty form. It has a reverse phase medium, and it's really what I consider one of the best bone products around. Any bone product that you're going to use should be ideally turning over as quickly as possible into the patient's own bone. So graft material is not something that we want to stay there. We want the patient's own bone to end up around an implant. An implant will only integrate into bone. It's not going to integrate into this stuff. So what this does is it acts as a filler around the bone, around the implant, preventing any inflammatory cells and any infectious cells from coming in, and at the same time acts as a matrix for the body's own cells. In other words, it's osteoconductive to come in, replace it, and then the body cells, the bone cells, will actually grow in there and fuse to the implant, and the implant will become histologically integrated in the bone. And actually, I'm going to connect my temporary component first. This is the temporary abutment. Okay? It's prefabricated. We use a multi-unit driver to grab it, and it has a screw that's going to go into the implant. It has a conical shape which mimics all of the abutments in the noble active system to allow for the biological healing that we want to get on top of the implant. But we are trying to create the natural gingival architecture around the implant crown, so that actually these implant crown restorations in their final state are not flush fitting with the head of the implant. There's this apical, this coronal taper that allows for a greater tissue volume development, so that you actually have a thicker tissue around the neck of the crown restoration. So these are just put in by hand, and that's what the temporary abutment looks like. And as you can see, that's pretty good placement. That's almost right in the middle of the extraction site. So you can see what I'm referring to is the design with this 3 millimeters of taper from the head of the implant to the base of the abutment. And that's to allow for soft tissue development. So we're going to get an increase in soft tissue volume around the neck, and then the actual crown will finish to this point here, because the final abutment will be analogous to that. And we're going to just fill the bone in here, and that's it. And we're going to take the Connexus, we're just going to squirt it into this space here. We're basically going to pack it around, and we're just going to overfill it a bit. And that's it. Then we're going to suture it. On top of this metal post, a little white sleeve from the temporary here. There's one more piece that you'll see actually in a second. This is what adheres to the acrylic. So this goes on top of the metal post. And now we're just going to suture this. And I've got a little bit of excess tissue, but that's okay because I want to have as much tissue as I can to cover the graft. Now for those who don't want to do a chairside temporary, you could actually take an impression of the implant at this stage, give it to your lab, and have them make a temporary. Just be careful, section. But the most important thing right now is that I just want the tissue to cover the graft material, so it's not going to go anywhere. And usually you'll get a little extrusion of excess grafting material, which is fine. Just section that away. Open. They should ban beards from dentistry. And I'm not worried about any excess tissue. I just want to keep that graft covered. And the excess tissue, you'll see, will just remodel. Sorry. The excess tissue will just remodel on its own. I'm just going to put one more suture in, and we're all done. So there you have it. You've got a really nice implant, well placed mesial-distally, buccolingually, and nicely sutured. Say pretty good closure, maybe 90% primary closure, so this graft area here is protected, and nice and dry. And we're going to make a temporary crown on top of this using our crown shell, or crown former that we had made. Implant surgery, you'd be using a surgical guide stent. In this case, I have a stent made, but I didn't use it because I had my socket site, so it would really be redundant. I know where I have to go in terms of the socket site, and I was manipulating the placement by hand using the properties of this implant system. What we're going to do, though, is use the surgical guide stent that we had made as an acrylic shell, or as a shell to hold the acrylic, which will be luted to this white plastic piece for making our temporary tooth restoration. This is the Osteotel Mentor resonance frequency measuring device. These are the little magnetic pegs, and what I'm going to do is I'm going to unscrew the abutment. I know that this abutment was torque challenged to 70 Newton centimeters. Between insertion torque and torque challenge. Insertion torque is just the amount of rotational energy that either the machine or your hand is exerting when you're placing the implant. But it doesn't tell you anything about the ability of the bone to resist displacement of the implant. Torque challenge is when you're actually testing the bone for any type of movement of the implant. And we know that any implant that can be placed at least 35 Newton centimeters can be considered for immediate loading. I'm a little bit more conservative. I like to have a torque challenge of at least 40 or 45 Newton centimeters before I'm going to put on an immediate temporary and have any type of function with it. In this particular case, when I placed this implant and I was pulling that bow is measuring the amount of torque that it would take to move the implant. And I could pull that bow all the way up to 70 Newton centimeters. So this implant is extremely stable. And I expect that when we do our Osteotel reading that we're going to get a very high number. So they come packaged. They're called Smart Pegs by Osteotel. And there are specific pegs for every single implant on the market. So it's not just for Noble Biocare implants, but for every other implant. Each implant diameter and each implant manufacturer will have, there will be different pegs for those implants. So I'm using a Smart Peg, which is specifically designed for a regular or wide platform Noble active implant. The restorative table for the wide platform implant is exactly the same as the restorative table for the regular implant. So I'm just going to unscrew this very quickly. And then I'm going to insert this. And you do this finger pressure only. You don't want to put more than 5 Newton centimeters of pressure. And you just push this button on. And all you want to do is hold this. That's 64, 68. It wasn't stable initially. So anything that's over around 65 to 70 is considered stable. So just it's very difficult to get these little pegs in between the teeth. And if they're not flush with the implant, then open, then you'll get a false reading. So that tells me that this implant is quite stable. The beauty of the Osteotel is that it gives you a numerical reading. And I know I'm starting already at 64 to 68 Newton ICQ reading, which tells me that I'm already almost at the stability level. Anything over 65 is considered osseointegrated. So this thing is not osseointegrated right now. This implant is mechanically stable to the point of almost being osseointegrated. And what I'm going to be doing is I'm going to be measuring the ICQ reading at subsequent stages during the healing process. And when I get over 75 or 70 to 75, I know that this thing is integrated and I can actually go ahead and put on my permanent restoration. So we're going to make the temporary now. And we have just a clear shell. And this was of the tooth before it fell apart. And this will just slip over his teeth, open. And what we're going to do is fill up the shell with acrylic, and we'll make him a temporary. The acrylic will fuse to the white piece, and we just hold it in his mouth for a few minutes till it gelates. Once it gets hard, we'll then take it out, we'll put it in some hot water, let it cure, then we trim it, and we make him the temporary. To make it easier, I took some acrylic, and we're actually using Snap acrylic. You can use anything you want, but I find that the methyl methacrylate, which we don't normally use for crown and bridge anymore, but for this we're using it because it sticks to that white piece better. The newer temporary acrylic materials that come in the guns, they don't seem to adhere to this white piece as well. And what Tahiri did is she painted very carefully some Vaseline on the teeth without getting it on the white piece. And now we're just going to slip this right on top. And I just take my fingers and I just mold it And all you really want to do is make sure that the acrylic doesn't get too hard that it's going to get caught into the embrasures and into the undercuts. So you got to keep your eye on this and just have it close. Just have the patient close like that. And then what I do is I take the residue that's in here and I just feel for it when it starts to get a little warm. And you ask the patient when they start to feel it getting a little warm, close. And then we'll take it out. Once we take it out, we'll just put it into some hot water, let it cure. I'll polish it, and we'll put it in. The patient goes home with a temporary tooth, which is a great service. Because really, implant dentistry today is obviously still about rehabilitation. It's root replacement. We have the ability now to give a patient a third tooth option. They were born with their baby tooth. The baby tooth got replaced by their adult tooth. And for whatever reason, if they lost the adult tooth, dentistry today can give the patient a root replacement for that lost tooth or multiple teeth. But we now have the ability with sound surgical principles and with good host bone to start with, and the ability to measure that bone, to evaluate the strength of that bone, to decide at the time of placement of the implant whether we can give the patient some type of restoration. And there's no better service than giving the patient a complete restoration, albeit it's a temporary, it's plastic, but it's still a tooth replacement that they can walk out of here today and they can function in a normal manner, whether it's eating, chewing, speaking, smiling, and every other way. Acrylic temp, so you can see it picked up the white piece. What you want to look for is to make sure that no acrylic gets beyond the margin of the white piece, so that means that the white piece was fully seated. And you could just leave it in here. I'm going to put it into some hot water. I'll trim it, then we'll just place it back on the tooth. And these have some type of internal connection that some people don't even use cement. I like to use cement so that they don't loosen. And you just put a tiny little bit of cement in there and we let it heal. We let the tissue heal around the temporary, and you'll see an unbelievable development of the gingival architecture right from this moment forward, because the tissue development is just as important as everything else. So we've replaced the root, we filled the defect with bone material, so we're going to actually regenerate the bone, and in addition, we're going to now develop the tissue architecture. So if you go back to the surgical site, look how no bleeding, there's really minimal bleeding, minimal trauma, and I would anticipate the patient will have minimal postoperative complications or sequelae. Because we manipulated the bone, because I extracted a tooth that was not in the best of shape yesterday, I am going to put the patient on an antibiotic today. I don't routinely use antibiotics, but in this case, just to cover him so he doesn't get any secondary infection. Plus, we did the scraping of the bone, and we did some bone grafting. We're going to put him on an antibiotic. We'll give him a painkiller, an option with some Tylenol 3. I doubt if he'll use them. Most patients will just use some NSAIDs, Advil, Motrin, whatever it is that they prefer, and that's usually sufficient. This is the Osteopulse by Biolux, and this is the device that's going to generate light therapy to promote healing of the new bone around the dental implant. And we are going to give this to the patient to take home, and the patient will have to wear this at home for 20 minutes once a day. And it has been developed to take advantage of a long researched phenomena that advocates the effect of light, red light or near infrared light, to have a positive effect on the cellular activity, actually on a certain component of the mitochondria, to produce enzymes that will promote cellular healing. And what the patient will do is, this is the control. we're going to plug this in like this, and it will tell you when you turn it on. So you turn on the device, and it'll tell you to plug in the receptacle into number 1. So I'm going to write the prescription now. And once I write the prescription, it will be set. So it says for 21 days. And I'm going to save that. You just push this button, and then you push this arrow. We plug this in and press this to start. And this red light will stay on to the surgical site for 20 minutes for 21 days. And as I said, we will get the patient back in day 10, day 14, and day 21. And we will use the same little smart peg that we had used before. We will remove the temporary component. We'll put the smart peg in, and we'll re-measure the ICQ reading. And we will see a gradual progression of a higher reading. The higher the ICQ reading, the more stable the implant is. And it gives us the ability now to augment what I know from the surgical procedure, which was where I did the torque challenge, which gave me already a significant high torque challenge reading. But this now will tell me the reading of the ICQ during the healing stage. And one of the things that we know about the healing around dental implants is that from week 2 to week 3, there's actually a little bit of a negative rebound where the bone actually weakens. And that's the time when we don't want to manipulate anything on the dental implant, because we're always worried that we could tip the scales in the favor of the weaker cells, or the osteoclasts, which are the bone-destroying cells, as opposed to the osteoblasts, which are the bone-forming cells. But with this light therapy, we are now confident that the patient will be able to have an uneventful healing and actually a more rapidly healing around the dental implant. And histologically, the bone cells that form the new bone cells and his own cellular activity will be promoted to work that much faster. So again, the protocol for the patient is very easy. He's just going to do this for 20 minutes every day, and that's it. And then he'll bring it back to me, and we'll be able to use this again for another patient. So I'm just going to disconnect this. That pauses it, and it actually tells you that we use like 2 minutes and 20 seconds. So when he uses it later today, he'll just finish up this cycle, and that's it. And then he'll use it again the next day. The patients can't cheat, because when he comes back, if he misses a day, it'll come back and it'll tell me 2 sessions or so were missed. So, and it won't work if the patient doesn't wear it. So if I take this off the patient, and if I try and start it, it tells me that the headset's not being worn. Please ensure it is correctly positioned. So it won't work. So it tells you. So the patient can't just push the button and leave it on the table. They actually have to wear it for it to work. So we're just going to disconnect this. You can see it's the acrylic is fused to the white piece that's going to go onto the post that's in the mouth. I'm going to just take some temporary cement. You can use any temporary cement you want. I happen to use this material, which is Kling. I buy it from Clinical Research. I'm just going to squirt a little bit into the hole, which is like that. And we're going to go to the mouth. Just very delicately cleaning off the cement. And what I want to do is get one picture to show you already how the tissue is thickening, or we've sutured it, and the thick tissue around the neck of the implant, because the neck of the implant is narrower in diameter than the body, there's more volume for tissue development, and you're going to see already a beautiful scaffold for tissue development. So you can see what I'm referring to in that there's room, a lot of room at the apical area of the crown towards the implant to build the acrylic out to help develop the tissue architecture. And in terms of post-operative instructions, as I said, we're going to put this patient on an antibiotic only as a preventative measure. There's nothing infectious there. We're going to give him some Tylenol with codeine in case he needs it. We gave him a couple of Advil. Probably Advil will be enough to keep him comfortable. And post-operatively, I'm going to give him a bottle of antiseptic rinse. I've gotten away from using the chlorhexidine rinses only because they have an unfortunate staining capacity, and patients would get very frustrated with the brown stain that would develop. They are, or have been in the past, the gold standard, but I've luckily discovered this product called the Natural Dentist. It comes from the United States, and it comes from actually a company in New Jersey called Natural Dentist. And a double-blind study was done at NYU under the auspices of Dennis Tarnow, where it showed no difference in the healing when patients would use this post-operatively as compared to chlorhexidine rinse. So I've been using this now for about 5-6 years, and it tastes much better than chlorhexidine rinse. It also is a product that doesn't leave any stain or any residue. And all we have the patients do is take a little bit of this. I give the patients also a very soft toothbrush. This is a post-operative brush. This is from Butler. And it has bristles that are analogous to a baby's bristle brush. And what they do is they just take a little bit of the rinse in the cap, they put it on the brush, and they can just very gently massage the area. If the brush is too sore, then we tell the patients to use a cotton Q-tip or even just a cotton ball. But we want to just keep the sutures lubricated 3 times a day with the rinse, and we want the rinse to just soak in around the neck of the tooth or the neck of the temporary to keep it comfortable. I also want to emphasize that the temporary tooth is in very, very light occlusion. There's no need to build this tooth up into occlusion because he's got his other teeth, and he's been without this tooth for so long anyways. This is really, the temporary here is, because it's a single tooth, is really needed or meant for tissue development, soft tissue architecture development, more so than the occlusion. If a patient is missing multiple teeth, then we'd have no choice. We do put them into occlusion, but then we're splinting them. And by splinting all the temporary teeth together, you're distributing the forces along the whole arch, and you're creating a greater surface area of force distribution. But because it's only one implant, to safeguard that he doesn't overload the implant and rock it out, we keep it in very light occlusion or even minimal occlusion. I've been asked by one dentist that before they start placing implants, what type of course should they be looking for and what type of cases should they be starting with? Well, obviously, there's a lot of education available today with respect to dental implants, and I think that it's important to get involved with a program which will teach one the basic skills, obviously the technical skills of placing an implant, which is not very difficult, but it's also must include the basic surgical skills, the principles involved in doing any surgery. And as well, the course should be comprehensive enough that should include some restorative componentry so that the dentist will actually know what to do with the implant. It's not enough just to place it, but you have to know how to restore it. And one thing that we teach when we are teaching dental implants is that it's the restoration that drives the surgery. So the technical skill training for placing an implant is really, really only a small part of the equation. But the real area that one has to focus on is the treatment planning and the case planning and then case management. So you must have that as part of any course. I would not, as an entry-level course, be worried about the bone grafting procedures, the sinus lifts and the ridge augmentations and all that, because that's way too complex and too much to absorb at the beginning. So really I would focus on a very basic course that would include the training or the skill development in placing an implant, but as well the treatment planning, case management, and restorative componentry. Another question I've been asked is what type of cement is best used for cementation of implants. I want to just clarify that we never cement implants. We always will make sure that any component that goes into the dental implant will be screw retained, whether it's an abutment or a crown. We want to make sure that that screw access hole is retrievable and accessible if the implant is ever needed for future use for any other applications. When we're talking cementation, we're talking about purely about cementing the superstructure, whether it's a crown or a bridge on top of the abutments that go into the implant. So fundamentally, it's important to understand that anything that goes into the implant body must be screw retained. And in terms of cement retention, for a crown, you can use any cement. There is no magic recipe. You can use polycarboxylate, you can use the resin bonded cements. Any of the brand names will work. I've used about 4 or 5 different cements and they all work really well. There is a cement that was specifically designed for retaining a porcelain fused to metal crown to a titanium abutment, and that's called Improv. That's a great cement. It's actually very strong, too strong for a temporary cement because you can't retrieve it. So if you do use that, it's advisable to mix some Vaseline or some type of lubricant with it. But you can use polycarboxylates, you can use Poly-F, you can use Maxim, you can use Panavia, you can use any of the cements from any of the companies that you're comfortable with. My preferred cement is Maxim by Kerr. I really like it. It works well, and it's very easy to clean up. The next question I'm going to ask is, do I recommend CT scans for all my cases? If so, which one would I definitely recommend to use and why? Well, we have a Panorex here. We have a digital panoramic X-ray machine in the office. That's a fundamental. You must have a Panorex. I will use a scan of some kind, whether it's a CT or a tomogram, only if I cannot tell clearly from my panoramic X-ray the location of the vital structures, meaning the sinuses or the lower border of the nose or the mandibular canal. But if I can see the anatomic structures clearly, then I'm not going to subject the patient for a scan unless it's for a guided surgery. If it's a guided surgery, then we need scans, and there are specific type of CT scans that are used to correlate the three-dimensional appearance of the bone with the actual restoration. But that's a totally separate training program in itself. If I have a panoramic X-ray and I can calibrate onto that X-ray the location of, let's say, the mandibular nerve, and it's within minimal working zone or working distance, then I might ask the patient to go have a scan so that I can actually get a 3D image of it to be safe and to make sure that I'm not going to encroach on the vital structure. But by and large, we probably refer about 30% of our cases for scans to get the extra information that's needed. The bottom line is that we want to provide our patients with safety and security in terms of the procedures that we're doing, and to make sure that at the end of the treatment that they're no worse off than they started in terms of having any type of infringement on vital structures. So if you're all in doubt, then definitely I would refer out for a scan. The last question is, when do we recommend immediate loading and what type of bone grafting materials do we use? Attempt is really to always give patients immediate loading. And we plan all our cases for immediate loading, whether it's a single tooth replacement, multiple teeth, or even a full arch. We have done cases where patients will come in with a denture, removable denture, and they'll walk out the same day with a fixed set of teeth. Our goal is to provide patients with immediate functional improvement and to actually get them out of a deleterious removable restoration that will only potentially cause damage to what's going on underneath, and that's a growing implant or a bone graft or whatever. We will make the final determination for immediate loading only at the time of the surgery, because we have to be able to assess the bone, and we have various tools to do that. We will use our torque wrench to torque challenge the bone to get a numerical reading in Newton centimeters that will give us some sense of security, of stability of the implant, and how much force it would take for the bone, on the bone, for the implant to move. And as well, we're using a new resonance frequency evaluating instrument called Osseotel, which will help us as well, give us a numerical ICQ number that gives us a baseline of stability of the implant at time of placement. Please remember that an implant at time of placement is mechanically stable. It should be mechanically stable, but it's only a mechanical placement of the implant in the bone. It's not histologically locked, and that will take 6 weeks or longer to get biological healing. Thanks for those questions, and hopefully you'll enjoy the presentation and find it informative. Thank you.